Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to talk about another 3 exciting Vivas from college exams. So before we dive into Vivas, Maddie, how's life and how's things post-COVID now?
Life's pretty good. Feels like things are getting slowly back to normal. We had a party for my uncle's 60th last weekend and there was like 40 people there, which was all in the same room, which was like actually quite nice.
It must be a dad joke party where everybody's sharing their dad jokes. Sorry.
Yeah, got some inspiration probably.
That's good. So let's begin with the first case for today. A 56-year-old male with a background history of gout and rheumatoid arthritis, admitted with 24 hours history of fever, joint pains, fatigue, cough, shortness of breath, and erythematous rash. Over the next 24 hours, the rash has worsened to involve his entire body. His chest X-ray is suggestive of widespread interstitial opacities, and now he has rapidly progressed to type 1 respiratory failure, needing intensive care admission. So, Maddie, what are your differential diagnoses here for this patient's presentation?
So my differentials are mainly drug-related, autoimmune disease or malignancy or an infectious cause. In terms of drug-related cause, this could be a Stevens-Johnson syndrome or toxic epidermal necrolysis syndrome. It could be a drug reaction with eosinophilia and systemic symptoms or DRESS. It could be something less like acute generalized xanthomatosis pustulosis or bullous fixed drug eruptions. From a other autoimmune or malignant perspective, it could be pemphigus vulgaris, a paraneoplastic syndrome or a paraneoplastic pemphigus, unlikely sweet syndrome or a severe acute graft-versus-host disease, which is unlikely unless this patient has had a recent stem cell transplant. And infectious causes, the most common ones, erythema multiforme, DIC, if this patient is very septic, or staph scalded skin syndrome, although this is less likely in the adult population.
Yeah, that's correct. So what are the features on history and examination would be important to evaluate the cause of this patient's deterioration?
So in terms of the history, it would mainly stem from first his presenting complaint and trajectory. So whether there was any systemic syndromes, any systemic symptoms such as a prodrome like a fever, a flu-like illness, or localizing signs of infection or lymphadenopathy, or any suggestions of malignancy like weight loss or cachexia. Medications would be particularly important because a lot of these disease processes are triggered by medications. So common causes of things like TENS, for example, would be things like allopurinol, certain antibiotics, especially penicillins, cephalosporins, tetracyclines, anticonvulsant use, especially carbamazepine, phenytoin, lamotrigine, and NSAIDs. And if these medications were in this patient's history, the time course between the commencement of these medications and the clinical manifestations would be particularly important. So, for example, it's a much shorter process in things like the acute generalized xanthomatosis pustulosis, which is just from hours to days from the start of the medication to clinical symptoms. Whereas things like TENS, it can be 1 to 4 weeks, or DRESS, it can be 2 to 8 weeks. The presence of comorbidities, especially things like malignancies, autoimmune conditions, or HIV, which causes an increased risk of TENS, would be important, and any allergies. And from an examination perspective, this would focus on systemic signs of infection, but more specifically on the rash itself. So the characteristics of the rash would be important. And there are different characteristics depending on the type of a pathology. So, for example, TENS has ill-defined erythematous macules with purpuric centres. For more information about the characteristics of this rash, this will be in the show notes. For another important thing is something called Nikolsky's sign, which is elicitation of skin blistering as a result of gentle pressure on the skin. So this is particularly present in TENS and staphylococcal scalded skin syndrome. And mucosal involvement distinguishes a lot of these skin conditions. So it can be involved with things like erythema multiforme, TENS, and DRESS, but it's uncommon in things like staph scalded skin syndrome or sweet syndrome. And then it'd also be important from a generalized perspective to look for signs of organ involvement, especially respiratory, cardiac, renal, hepatic, and CNS involvement, which is more common in certain conditions such as DRESS, TENS, and sweet syndrome.
Yeah, and as you mentioned, you're concerned about that this patient may have toxic epidermal necrolysis. So what are the investigations that would help you to make this diagnosis?
So the major one is a skin biopsy. So there are different stages and findings depending on the stage. So in early stages, you might see apoptotic keratinocytes in the basal layer of the epidermis. And there's a mononuclear infiltrate in the dermis, which is composed mainly of T lymphocytes. But this is a very non-specific finding. Later, there can be the formation of subepidermal bullae and full thickness epidermal necrosis. And the direct immunofluorescence is always negative in TENS. Other contributing findings that would aid in the diagnosis would be an evaluation of the organ function, as organ involvement can be a feature of TENS. So an ABG would be important to look for gas exchange, metabolic parameters, and the glucose, as mucositis can make oral intake difficult. A full blood count as anemia and lymphopenia is quite common. LFTs might show hypoalbuminemia and a transaminitis. Electrolytes such as UEC and CMP might be imbalanced depending on the extent of skin involvement. And then consideration of alternative diagnosis, so considering things like ECGs, troponin, lipase, and CK, which might be involved in things like DRESS. A septic screen would be important, as infection can be a cause of this rash and it can also be a precipitant. So looking for sepsis with blood cultures, and also bacterial superinfection of the wounds can happen. So looking at swabs of the wound. And then serology for mycoplasma, which can be a trigger for TENS, and then HIV, which can predispose to it, and then swabs of the lesions for things like HSV. Imaging is important to look at causes of the hypoxic respiratory failure or alternative diagnosis, so a chest X-ray, and consider further imaging such as CTs to evaluate for malignancy and infections if indicated.
Yeah, so obviously as an intensive care trainee, it's very hard to know everything about toxic epidermal necrolysis because we don't see these patients quite often in unit. This is pretty rare occurrence to be to see these patients in intensive care. But when you see this, obviously they can be challenging to manage as well. So what are the kind of key management principles when the diagnosis is toxic epidermal necrolysis?
So I think this can be thought of in terms of the specific management, including the specific for TENS and specific organ support and supportive overall ICU management. So the specific management, the major thing is, as this is precipitated by certain drugs, is to identify and stop the culprit medication. So which would involve a thorough history and the time course of the medications that the patient's been on. There has been interest previously in the use of IVIG, hydrosteroids, and plasmapheresis, but these have conflicting evidence and there's no clear consensus currently on their role in TENS. But there is some growing evidence that cyclosporin use may be beneficial early in the course of TENS, but this will obviously require some multidisciplinary input. In terms of specific organ support, mucosal involvement is very common and can be very severe. So ocular involvement should necessitate early off-bowel involvement and can involve saline rinses, topical steroids, lubricants, and sometimes topical antibiotics. While this patient is male, in females, especially urogenital involvement can cause long-lasting sequelae. So early gynecological involvement is important, and the use of sometimes intravaginal corticosteroids and soft vaginal molds. In terms of oral mucosa, mouthwashes and lozenges can be used. And wound management is very crucial. So this involves dressings, avoiding hypothermia and insensible losses through the wounds, and fastidious care and monitoring for superimposed infection. So sterile handling, repeated cultures, and sometimes early initiation of antibiotic, kind of like burns patients. From a respiratory perspective, supplemental oxygen can be required, physiotherapy and humidification of any oxygen. And depending on the level of respiratory involvement, it might require further respiratory support and intubation. And then generalised supportive care is important. So multidisciplinary management, generally in intensive care or a burns unit. Nutrition is crucial. So sometimes the early careful placement of an NG tube in severe cases, and monitoring of fluids and electrolyte balance. It's generally they don't require as much fluid resuscitation as burns. It's thought to be about a third less replacement in terms of volume for an equivalent body surface area. And consideration of line side access with early PIC if required. Multimodal analgesia, as these are often very painful, and then things like VTE, ulcer prophylaxis, and IDCs.
That's a very comprehensive list of interventions that these patients need. And often the vascular access is the one which is always going to be challenging. So early center line or PIC line is important. Now, Let's move on to the second Viva for today. A 76-year-old male presented 4 hours after the onset of acute severe chest and back pain, and he is currently hypotensive with a systolic of 80 millimeters of mercury. His background history is he got hypertension and 40 pack years of smoking. So, what are the life-threatening causes, and what findings on clinical examination that you would seek to differentiate between these different causes?
So I think the major cause is thoracic, but one of the abdominal causes is potentially an intra-abdominal perforated viscous. In terms of thoracic causes, this could be vascular, such as an aortic dissection or an AMI or a PE, or it could be an esophageal perforation or a spontaneous tension pneumothorax in this patient with potential bullous lung disease from their COPD or with the 40-pack year smoking. So in terms of aortic dissection, findings on the clinical examination would include radial delay, a differential BP between limbs, and potential signs of the dissection. So neurological signs such as Horner syndrome or stroke, loss of pulses in the upper extremity, paraplegia, abdominal pain from mesenteric ischemia, or a new murmur such as new aortic regurgitation. So all signs of tamponade, he's already hypotensive, but soft heart sounds, raised JVP, or lower extremity pain or weakness. In terms of esophageal perforation, signs might be just generalized, such as shortness of breath or tachycardia, or could involve subcutaneous emphysema, decreased air entry on one side from a pleural effusion. AMI is also mainly generalized signs such as diaphoresis and shortness of breath, sometimes hypotension, or signs of heart failure or valvular failure with a new murmur. A tension pneumothorax, there'd also potentially be desaturation, unequal chest movement, no air entry on one side, hyperresonant to percussion and subcutaneous emphysema, and the tracheal deviation may be away from the affected side. And a pulmonary embolus, signs are generally minimal, but might have signs of an underlying DVT, such as calf pain or swelling, and then a clear chest on auscultation with tachypnea, tachycardia, and hypoxia. And then in the intra-abdominal life-threatening one would be a perforated viscous causing a tender abdomen with guiding and rigidity, and maybe referred pain with this referred chest or back pain.
Yeah, that's correct. So you are concerned about a thoracic aortic dissection. What investigation could be performed to make this diagnosis, and what are the advantages and disadvantages of each investigation?
So there are bedside tests, which include an ECG, a chest X-ray, and an echocardiogram, imaging, which are mainly CT, aortogram, or an MRI. So bedside tests, an ECG you might be normal or have non-specific ECG changes or signs of left ventricular hypertrophy. The advantage of this is that it's cheap. We perform it basically in every patient. It's easy to perform and may point to other diagnoses such as a STEMI or signs of a right heart strain in PE. It's non-invasive and not resource or labour intensive, but it's very non-specific and has poor sensitivity. So it wouldn't be the sole test of choice in an aortic dissection. A chest X-ray findings might include a widened mediastinum, double aortic contour, irregular aortic contour, or unexplained unilateral pleural effusion. And if there's a mediastinal hematoma present, there might also be obscuration of the aortic knob, apical capping, especially on the left, and deviation of the esophagus and trachea to the right and the left main bronchus inferiorly. The advantages of this is it's rapidly available. It can point to other pathologies, such as things like a pneumothorax, and it's cheap, but its disadvantages, there's some radiation, it's very poor sensitivity as well for an aortic dissection. And the final bedside test that can be done is an echocardiogram. This can either be a transthoracic or a transesophageal. And you might see a dissection flap or a dilated aortic root or some signs of tamponade. The advantages are that a transthoracic echo is minimally invasive. And for both the transthoracic and TOE, it can assess the valves and the left ventricular function. It's got moderate sensitivity and specificity for an aortic dissection, doesn't require contrast, and it allows things like detection of tamponade and the assessment of proximal coronary arteries, and is able to detect an intramural hematoma, the intimal flap, and the true and false lumen, and is rapid or immediate results. The disadvantages for a TOE, specifically, it's invasive and it requires sedation and maybe airway protection, might cause hypertension, which can worsen the dissection, and there's less availability and can cause esophageal trauma. And for both TOE and a transthoracic, all the accuracy is very operator dependent. and requires specialized expertise. And there's a blind spot due to the interposition of the trachea and the left main bronchus between the esophagus and the aorta. And it can't evaluate the distal extent often of these dissections, and it can't visualize properly the abdominal aorta. So the last three tests are imaging modalities, which are CT, aortogram, and an MRI. The CT advantages is that it's readily available, has rapid results, high sensitivity and specificity, and provides information about the end organ ischemia that might be affected by the dissection flap. And it can also help for planning of surgical or endovascular treatment, can exclude other conditions that might mimic a dissection. And it's generally the test of choice we use these days. Disadvantages are that it requires contrast. There's always the risk of transfer to and from CT, as well as monitoring of the patient in the CT. Requires expert radiology interpretation and does not provide information about the valves, coronaries, or the left ventricular function. The aortogram is the next test that could be used, and the advantages are that it's highly sensitive and specific, and it allows for assessment of the valves, the LV function, tamponade, and coronaries, and may actually allow for endoluminal repair during the same procedure and provides better anatomical details than the other tests. But it's got a high contrast load. It's not readily available. It's time consuming and has risk of the transfer and risk of arterial access and requires specialized skills and is quite invasive. And finally, the MRI is very sensitive and specific, but has less nephrotoxic contrast. It gives information about end organ ischemia and allows planning for potential intervention. But there's significant risk of transfer and monitoring. It's less available and requires specialized expertise to interpret. And certain populations can't have an MRI, such as if patients have certain pacemakers.
Yeah, I guess that's probably why everybody likes to do CT scans, which will still give the adequate information to act upon. So what are the key management principles for this patient?
So the key principles about specific management, including a surgical and interventional plan, and then supportive management. So specific is mainly with an aim to prevent further propagation of the dissection flap by reducing the aortic wall stress. And the way we do this is reducing the heart rate and contractility, generally aiming for a heart rate less than 60, and usually intravenous beta blockers such as labetalol or esmolol are used. And then once the patient's adequately beta blocked, to reduce the blood pressure, generally we aim for a systolic about 100 to 110 or 100 to 120. There's different criteria depending on your institution. And this is usually with infusions initially, such as GTN or SNP, and then transitioning the patient to oral antihypertensives. It's also important to formulate a surgical or interventional plan, so liaising with the cardiothoracic or vascular surgery regarding the plan for treatment. Some dissections, such as uncomplicated type B dissections, are conservatively managed generally. And then supportive management is necessary, so having the patient have adequate IV access and monitoring disposition-wise or need ICU generally initially. Having hemodynamic monitoring, such as an arterial line, and generally they'll need a central line, and IVC and full cardiac monitoring, and preparing for the worst case scenario. So ensuring there's a valid group and hold and cross match, and monitoring for propagation of dissection flap and for end organ impairment. Allowing for adequate IV fluids, correcting any medical kind of coagulopathy. Generally, these patients are placed on bed rest initially, and then trying to limit any pain and distress that the patient might be suffering from. So having adequate analgesia and a calming environment as much as possible.
Yeah, that's correct. So that's the good, very comprehensive answer, Maddie. So let's move on to the last viva of this podcast. So 25-year-old female, day 4 in ICU after diving into a river and hitting a submerged object, which leading to near drowning and aspiration of a large volume of river water. Now she has progressive bilateral infiltrates on chest X-ray and is requiring a FiO2 of 60%. So along with high levels of PEEP, and she's barely achieving the SATs of 88% with a PO2 of 60 millimeters of mercury. How would you decide whether the proning is an appropriate option for this patient at this time?
So this would depend on disease-related factors, specific patient-related factors, and logistic issues within the institution. And it would involve an assessment of her history, especially her trajectory in ICU, examination and focused investigation findings. So in terms of disease-related factors, it's important to consider her trajectory in ICU. Is the hypoxia worsening or improving, the amount of PEEP and ventilator settings she's on, and whether there's any complications from these ventilator settings, such as the need for high driving pressures causing barotrauma. And then considering any reversible pathology that we can optimize. So evaluating her vitals, her lung fields, ventilator settings, gas exchange, and recent imaging and micro. So potential causes would include tube-related factors such as obstruction, which can be optimized by maybe secretion management and positioning of the tube, infection, so looking at her antimicrobials and cultures and whether she's on appropriate antibiotics, her fluid balance, whether she needs diuresis or chest drains for effusions, whether there's sputum load, so whether she needs a bronchoscopy, any pneumothoraces that needs drainage, any cardiac failure that might need inotropy or diuresis, and any dysynchrony, so whether she needs increased sedation or paralysis, or whether she's on appropriate ventilator settings. In terms of patient-related factors would include the body habitus of the patient and whether she has any other injuries from the diving accident, so any spinal injuries or precautions, any abdominal injuries, pelvic instability, abdominal distension, traumatic brain injury, or refractory raised ICP, or any unstable fractures or significant chest wall trauma or anterior chest drains that may preclude prone positioning. If there's significant hemodynamic instability, that might make prone positioning difficult. If she's pregnant or in late-stage pregnancies, which is not an absolute contraindication, but does make prone positioning very tricky, and any other background comorbidities and her grade of intubation, which would be important to consider in terms of the easiness of proning her and if the tube was dislodged. And then in terms of logistics, this would be very important because it require consideration of the familiarity with proning within the centre and the staffing, because it does require quite a few people in order to prone and unprone this patient.
Yeah, that's correct. So I guess with the COVID, we are very well experienced with proning, and obviously it has become much easier. So what is the rationale behind proning a patient with a hypoxemic respiratory failure?
Rationale, there's several advantages to proning. So one of the main ones is improved VQ matching. In ARDS lung, there is a significant VQ mismatch in the supine position. So blood flow is greatest in the dependent area, but so is alveolar collapse. So that alveolar ventilation is greater in the non-dependent areas of the lung, but the blood flow is less. The prone positioning improves VQ matching as ventilation and perfusion becomes more uniformly distributed, and previously collapsed alveoli are recruited. Prone positioning also results in more homogeneous alveolar ventilation. So it reduces the difference between the dorsal and the ventral transpulmonary pressure, which estimates the distending pressure across the lung. In ARDS lung, the dorsal pleural pressure is greater than the ventral pleural pressure, resulting in more overinflation of the ventral alveoli and collapse of the dorsal alveoli. Prone positioning reduces this difference, thereby reducing the risk of overdistension and cyclic atelectasis, and thereby reducing the risk of ventilator-associated injury. It also reduces lung deformation because while supine, the heart and the diaphragm compress part of the lung, but in the prone position, the heart is dependent and the diaphragm is displaced caudally, which decreases this compression of the lung. It also increases functional residual capacity a little bit, but this is not thought to be cause a big effect on oxygenation. And it theoretically enhances the drainage of respiratory secretions and may increase cardiac output due to reduction in hypoxic pulmonary vasoconstriction, which results in increased right ventricular preload and decreased right ventricular afterload. And it also is thought to improve the chest wall mechanics in obese patients.
Yeah, that's correct. So what are the risks of prone positioning?
There's several risks. The first one's mainly surrounds logistical issues. So in the prone position, as you can imagine, there's poor control of the airway, drains, and any lines. So there's risk of accidental extubation and dislodgement of things like chest drains and CVCs. If they were to be dislodged, it's difficult to reinsert any CVC, or impossible almost or reintubate the patient. It's difficult to perform CPR or defibrillation if required. And then it's difficult to monitor the patient, difficult to position them, and there's an increased staff workload because of the proning and unproning that's required. There's also increased risk of pressure areas to the patient, especially on pressure-prone areas such as the ASIS, the knees, scrotum, lips, and the bridge of nose. There's increased facial edema and increased risk of retinal damage if there's not adequate eye protection, and increased risk of nerve injury, especially the brachial plexus and the ulnar nerves. There's poor NG tolerance and risk of aspiration due to compression of the abdomen, and it results in increased ICP and intra-abdominal pressure and hemodynamic instability such as arrhythmias and hypotension. It may also delay the initiation of other therapies such as ECMO, which might be required.
And I guess most of the complications are becoming lesser and lesser now because of the very good training around proning. And I guess the ICU nursing staff does amazing job looking after these patients. And I guess the amount of time it takes now to prone is much, much less than it used to take before. So I think overall, after COVID, every ICU has become much more comfortable and competent in proning patients.
During COVID, we were proning so many patients. So by the end, it was much slicker than the beginning.
It was funny that even orthopedic registrars came to ICU and helped with the proning. And they were so quick to prone someone. It was quite good fun, actually. It's a great teamwork. Now, what's the actual evidence behind the usefulness of proning in these patients?
So the major trial that we refer to is the PROCEIVA trial, which was published in 2013. And this studied 466 patients with severe ARDS and randomized them to prone positioning for at least 16 consecutive hours a day or a semi-recumbent position. And this study had quite impressive results and found that 28-day mortality was significantly lower in the prone group with no difference in the ICU length of stay or complications. So this is the major sort of landmark study that we've been using for the rationale for prone positioning. A 2015 Cochrane review looked at 9 RCTs and actually found no significant difference in mortality with prone positioning, except in 3 subgroups: those who were proned within 48 hours of meeting the entry criteria, which was generally severe ARDS, those prone for 16 or more hours a day, and those with the more severe hypoxemia. But this review did acknowledge that it was a very heterogeneous group of studies and low quality evidence.
Yeah, the PROCEIVA trial was the amazing trial because first of all, it's very hard to do these kind of trials, and that showed 50% mortality reduction, which has never heard of, especially in the patients with ARDS after the low tidal volume protective lung ventilation study. But obviously, after PROCEIVA came out, nobody actually adopted the practices, and it took COVID to come. Then suddenly everybody almost forgot about ECMO and everybody started proning patients. And now we prone almost 5, 6, sometimes 7 or more than 7 sessions any patient before we even think about ECMO. So I guess it has become obviously the new way of treating patients with hypoxemic respiratory failure. And in future, I think we are going to see more use of proning. So yeah, definitely it's worth thinking about. And also from the Viva point of view, I think this might become a very important Viva question for at least next couple of settings. So Maddie, that's the end of our all 3 Vivas. With that ongoing rain, I was hoping that you might not have get any chance to think about your jokes.
No, I think that's why we need it more, because it's been so miserable and wet everywhere.
So you want to add to that misery, is it? Okay, go ahead.
Oh, no, bring joy. Okay, so I've got one. Why are dermatologists so invested in their patients?
It's not the truth, though. I never seen dermatologists in ICU. Because they get tense?
No, because they always have skin in the game.
That was good quality joke. I must say that takes some sort of neurons to have in your brain, which I don't. Anyways, well done, Maddie. So thanks, Maddie, and thanks, folks, for listening to IC Fellowship Podcast. We'll be back in months' time with another episode. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.